Pierre, what is the contribution the Entscheiderfabrik makes to allowing for an exchange of expertise between the German and the US health systems?
Yeah, our job as the Entscheiderfabrik is to show the decision makers in the hospitals the chances and the risk of the digital transformation in our disruptive times. So for us, it's we do this with workshops, with voting the 5 key digitalization topics in healthcare in each year in Germany. But in addition, we also go for, I think it's the 10 years to the US to have the view over the horizon. And in the first years, we go from this coast to this coast, for this hospital. And since 2015, we stay with our US friends in San Diego, and we established a very good alliance also with the College of Health Information Management Executives, and working in several aisles and to establish an exchange on health IT and on special medical topics like precision medicine, like management, change management, and we think we are on a very good way. Yes?
Very good. So we're here at the annual Congress of the German Hospital Directors Association. A couple of questions in the context of that and your presentations here. Larry, how is the reimbursement system changing in the US?
Thanks for asking that question. The reimbursement system is actually changing in very profound ways. Before I answer that question, though, I would like to make the statement that the cost of healthcare in the United States as a percent of GDP is about twice of what it is in Germany, and our outcomes are not twice as good. And so there is a burning platform in the United States to bring down costs and to make healthcare more efficient and our outcomes better. So with that as a background statement, we are shifting away from just DRG-based reimbursement fairly quickly into a process called value-based healthcare. And it's really a transformation from volume, so how much you do, to value and the value you bring to the healthcare system. A lot of this is based on a lot of the writings of Michael Porter from Harvard Business School. Has written a lot about that topic, both in healthcare and in other industries. But as an example, right now the funding in healthcare predominantly is due to people getting sick. And the change is to try to incentivize and encourage both doctors and healthcare systems, so hospitals, to keep people healthy. And the payments will be based on populations of patients taken care of. And the incentives will be to keep people healthy, keep them out of the doctor's office, keep them out of the hospital, prevent heart attacks, prevent strokes, and provide alternative types and sites for healthcare. So, for instance, in the past with a knee replacement, patient would be admitted to the hospital and maybe stay for a few days for the knee replacement and then be transferred to a short care nursing facility or an assisted living facility. Now, currently, at my hospital at University of California, San Diego, most patients are getting knee replacements in the morning and sent home at the end of the day, with all of those with physical therapy, with nursing, with IV antibiotics and so forth, set up at their house so that they just have one day in the hospital and don't have to have a prolonged hospital stay. That's a good example of sort of a bundled payment and the way both the process and payment is changing. And by the way, the outcomes for that are excellent, as good as the alternative.
So Ken, please let us have your statement on this.
Yeah, being in San Diego, Southern California, we've been in what's called managed care, or what we call a capitated form of care. So we're at what I'd call the most advanced stage of value-based care. About 35% of the patients that Sharp cares for, we receive a per member per month premium. So we're very incented to keep the costs down, to keep the patients well, and to try and keep them out of the hospital. So, we have done a lot to invest in coordination of care. How do we tie things together? How do we manage the most effectively with the right resources? And then, as Larry talked about, even alternatives to care. So a little bit of what we've done is looked at home monitoring, telemedicine, and those kinds of programs, because we don't have to worry about getting reimbursed for it. For those patients that we have capitation on, it's whatever the best care and the lowest cost care is. So, we've been doing a lot of that. At the same time, we're seeing tremendous pressures from the commercial payers and the governments that continue to squeeze down the dollars that are being paid, and a lot of efforts going through the programs that Larry talked to, moving to shifting more to a value-based program.
So what is the role of digitization in allowing for this change?
Well, I think it's a number of bases. The first is really what we did across the U.S. as far as the implementation of the EMR. So we had to get the basic data captured from clinical care, and then get that available and coordinated across the care continuum. So you saw a lot of organizations invest in single systems from Epic or Cerner like that, or like Sharp has done, where we invested in an internal HIE to create a longitudinal record. So that was kind of the first thing we did, and that was the early stages of digitization, but it also helps be able to better manage the care if you understand the care across the continuum. I think the other things that are going on today are really around engaging patients more effectively. So how are they being engaged in their care? For early starts, we're like patient portals to give them availability of the information about what's going on with them, what the outcomes are, and then it's starting to look at them and how do they get active and engaged. So in a lot of our patients, we're actually setting up plans of care. We're looking at monitoring on an ongoing basis to make sure they stay true to what they're being prescribed, taking medications, doing their exercise. And then I'd say the third area is how do we extend care using digitation and technology to the home setting. As I mentioned, telemedicine, it's a lower cost process of care. It's also makes resources more available, allows us to, I think, expand our services without actually having to hire more physicians or build more clinics. So it helps keep that cost down.
So several examples. The basic management principle is if you can't measure it, you can't manage it. I think is a good principle for digitalization, because digitalization has allowed us to be able to measure almost virtually everything that we do in the healthcare setting. So, for instance, taking care of a patient with diabetes isn't as much as monitoring just their blood work. It's really looking at their total outcomes of their care. And we're starting at the individual doctor level to be able to look at quality outcomes per doctor, per population of diabetic patients, looking at outcomes, looking at cost of care. And insurance companies, both commercial insurance and government insurance, is going to start shifting patients to the doctors who provide the best outcomes at the most effective, efficient cost. So that's going to be one example of a pretty profound change in the system. Without digitalization, that would not be possible.
Okay, so we